So before we open up this Lunch and Learn to a phenomenal panel discussion, I wanted to give a very brief overview of actually why this I felt was such an important topic for us to address. The fact of the matter is we know that there are a lot of biases that we see in the medical field, even in society, and it's really the most important pressing thing that we look amongst ourselves on how to remove those biases in order for us to actually change the way we care for patients, but also even our colleagues. And I wanted to very briefly give you a few statistics from a gender as well as race perspective. And when we think about particularly women in the field of cardiology, despite making up 70% of the healthcare sector, women make up just 14% of practicing cardiologists. And as a result, we also know that they're paid 12% less. They make up only 25% of leadership and decision-making positions. They have fewer opportunities at clinical subspecialties, scientific meetings, journal editorial boards, and lower likelihood of promotion. A lot of what they encounter during their career is misogyny, structural sexism, and gender discrimination. Beyond that, though, when we think about underrepresented racial minorities, we know that these are members of racially diverse groups that make up greater than 33% of the United States population, but only comprise about 7% of practicing adult cardiologists in totality, ranging from Asian, Black, Hispanic, American Indian, or Alaskan Native, as well as Native Hawaiian or Pacific Islander physicians. So a very, very low percentage in the field of cardiology. And although numerous pipeline programs are out there that are directly addressing sex, gender, race, ethnicity in the physician workforce, we know that a lot of data, unfortunately, is not out there for those of sexual minority clinicians. The fact of the matter is that one reason could be that there may be the need to protect individuals who identify as the LGBTQIA+ community. It should be standard practice to receive voluntary demographic data, but in a 2015 survey, more than 30% respondents stated that they concealed their sexual identity in medical school because they felt uncomfortable that they would be discriminated against. Now, the pathway to diversity, equity, and inclusion must change its course. We know that a lot of individuals and institutions and societies are prioritizing toting messages about diversity, equity, inclusion, and belonging initiatives that absolutely increase the pipeline for many of these women and underrepresented minorities in medicine to training programs and practices to help increase diversity in the cardiovascular profession. We know that similar pipelines have to be out there for sexual minorities and other diverse populations, but we have to move beyond those pipelines and actually think about how can we address the plight of women, sexual minorities, and underrepresented minorities, and other diverse trainees and practitioners based on what they face in the workplace, which includes misogyny, racism, and discrimination. This could come in the form of microaggression, biases from patients, colleagues, as well as the system they work within. Only then will we actually be able to change the plight of our patients that are experiencing it as well. So really, to think about this, to bring about change, you must not be afraid to take the first step. We will fail when we try. And as it stands, most healthcare systems and training programs don't necessarily go past explaining the science behind bias and discrimination and its cost. It's a fatal flaw to think that we can reduce outcomes by just being aware that they exist. The issue is that diverse healthcare clinicians often remain silent about the experiences with sex, gender, race, ethnicity, sexual orientation, religion, and other forms of bigotry that they encounter in medicine. And the majority of clinicians who witness such acts also remain silent, and they fail to intercede on their colleagues' behalf. The easiest solution would be, let's require all healthcare workers to receive implicit bias training, particularly on how to facilitate a dialogue that can productively challenge racist or other biased behaviors. Let's create hospital support networks so diverse clinicians could candidly discuss moments in training and practice that when they've been actually discriminated against, or even let's encourage increased agency and provide support and access to career building opportunities despite a perceived threat to the status quo, something where we want to prevent implement a term, pet to threat, where we know that as it stands right now, as an example, Black women in higher positions, initially perceived as likable, moldable novices, become more suspect as they grow in their jobs and exert the influence and authority that they've earned. So let's move away from that environment. The issue is how it's not an easy task, because many organizations worry about backlash to mandate such implicit bias training. As a result, they make it voluntary. We also know that organizations don't collect information on the metrics that they claim to care about, so how can we improve something we're not actually tracking? And many within the organization perceive bias is actually not even common, creating a perpetual blind spot. And this is something that we have to look within ourselves, is if we ignore racism and sexism, it's not going to go away. We have to move away from that fear zone where we are comfortable and trend closer to that learning zone where we have to educate ourselves on the disparities that we're seeing from a gender, race, ethnicity, as well as other diverse population perspective. And we really need to strive to get to that growth zone where we not only educate ourselves, but we educate our peers and we start to speak out when we see racism or sexism in our field. In order to do that, we have to be an ally. We have to listen, we have to call it out, as I said, we have to get comfortable with being uncomfortable. We have to think about our implicit bias daily, support organizations that are working to end it. We have to also not act blindly, because you can't actively fix something you cannot see, right? It limits your ability to appreciate individualism. We have to evaluate for microaggression in ourselves, in our workplace, and actively recruit diverse healthcare clinicians and staff, and ask your diverse colleagues if they would like to discuss their feelings, their stress, their fears, and acknowledge the daily impact this has on their physical and mental health and well-being. And we need to work to mitigate the struggles they face in today's society. And at this point, where we're now going to open it up to our phenomenal panel, I personally would say that I no longer want to accept the things I cannot change, but I want to change the things that I cannot accept. And as a result, in order for us to do that, that's the only way we know that we're going to see improvements in the disparities that we're seeing. So with that, I would love to have the opportunity to introduce very briefly our panel of our faculty speakers. I'm going to reintroduce Dr. Sharonne Hayes, who is our keynote speaker and the professor of cardiovascular medicine at Mayo Clinic in Rochester, Minnesota. I'm also going to introduce Dr. Keith Ferdinand, who you've heard already a lot from, which we are so thrilled. Dr. Ferdinand is a professor of medicine at the Tulane University School of Medicine. He's a specialist in clinical hypertension, where he's the endowed chair in preventive cardiology. He has conducted numerous trials in hypertension, lipids, cardiometabolic risk, and cardiovascular disease, especially in racial and ethnic minorities, with over 200 peer-reviewed publications and lectures nationally as well as internationally. In 2004, Dr. Ferdinand received the Lewis B. Russell Jr. Memorial Award of the American Heart Association. Other awards include the Congressional Black Caucus Health Trust for Journalism, the Charles Drew Award for Medical Excellence from the National Minority Quality Foundation, and the Wenger Award for Medical Leadership by the Women Heart and ABC Spirit of the Heart Distinguished Leadership Award in 2019, as well as the Xavier University Champion Award for Equity as well. We are also being joined on our panel in person by Sonora Crittenden. Sonora is the manager of community benefit and health equity at Dignity Health at St. Joseph's Hospital and Medical Center. In her current role, she's developed and participates in strategic collaborative partnerships with hospital and community stakeholders to advance community health initiatives and proactively promote the elimination of health disparities and the achievement of health equity for all. Virtually, we are joined by Dr. Nezar Falluji, who is the Vice President of the CommonSpirit Health Cardiovascular Service. He's an interventional cardiologist who practices in Lexington, Kentucky. He specializes in structural, coronary, and peripheral vascular interventions. He is part of the CHI St. Joseph's Cardiology Associate Group and is a founding board member of the CHI St. Joseph Medical Group. He also serves as the medical director of the Structural Heart Program and the Cardiac Cath Lab at St. Joseph's Main Hospital. And lastly, all the way from the United Kingdoms virtually, is Dr. Mamas, professor and the associate editor of Circulation Cardiovascular Interventions, as well as a board member of the European Association of Percutaneous Cardiovascular Interventions, the European Society of Cardiology. He's the clinical director of the Center for Prognosis Research at Kiel University and leads a group of clinicians, data scientists, and statisticians whose research interests focus around the use of routinely collected electronic healthcare data to inform the diagnosis, treatment, and clinical outcomes of real-world patients with cardiovascular disease. He's published over 500 peer-reviewed manuscripts using big data in populations with cardiovascular disease and has a wide range of interests, including women's cardiovascular health and cardio-oncology. And with that, often, for those in the audience, in the United States of America, there is a rigid dichotomy between communities of color as well as the healthcare system that serve them. Many diverse communities present to health systems that are staffed by very limited number of physicians, or diverse physicians, more importantly, as well as mid-level practitioners. New Orleans and Tulane University School of Medicine is a key example of this dichotomy. So my first question is to Dr. Ferdinand. Can you break down for us the historical context of this and what it may mean for the ongoing lack of diverse representation in medicine, especially in leadership roles as compared to the diverse community we tend to serve?
Well, I'll try not to go on too long. I'm a native of New Orleans. I'm a child of the lower Ninth Ward. Most of you didn't know it was before Katrina. That was the area that was so heavily flooded. And if you look at those families sitting on the roof, waving T-shirts and flags, come save me. I actually lived that experience in 1965 in Hurricane Betsy. Same levees broke, same area. Lost my grandfather, was on the roof for 3 days, no food, no water. So where you live, the social determinants, that's the harshest example I know of personally. Where you live has a great impact on how you're able to survive. Tulane University is the second oldest medical school in the United States. It's been around 137 years. And they know how I feel. I'm there because it serves my people. It's the second largest employer in New Orleans. But for 120 of those years, they had to watch people nurse their children, cook their foods, clean their streets, and say, yeah, I see you, but I don't want you to go to school with me. I really don't know how they were able to do that. I can't think of the mentality that would allow you to be in a city which is, minority is a funny term because it's predominantly people of African descent, and there's some now Vietnamese and Hispanic populations. So it's a majority-minority city if you want to use those terminology. But how you could do that and then not want to have a diverse student body, a diverse leadership, again, I don't understand. No one's really been able to explain it to me. I think the answer is to realize that everybody's playing golf. In golf, you play the ball where it lies. If you hit it in the rough, you play in the rough. You hit it in the green, you hit it in the green. If you get a good shot, you play it. You get a bad shot, you play it. So I don't personally hold a lot of animus about the past history. What we attempt to do is to look at, for instance, in entry-level positions, not just what named school the person came through and what kind of big title they may have had when they come for a position, but what they bring, their commitment, their understanding, their passion for being at Tulane and being in New Orleans. We do diversity training. I bristle a little bit because diversity training has now been distilled to looking at a video and answering some multiple choice questions, and you get a certificate and the dean puts a little stamp next to your name, you've done diversity training. I think it has to go deeper than that. We're probably going to have to do some more in-service talking to each other, face-to-face, on what we can do to transform our institution. So that's where I'm at, brief.
Thank
you.
you.
Go on for hours if you want.
We can do that after this session. Thank you so much, Dr. Ferdinand. And I think it transitions very nicely into bringing Sonora into the conversation. So as the manager of the Community Benefit and Health Equity Committee at St. Joseph's Hospital and Medical Center in Phoenix, Arizona, you truly do impact some of the most diverse members of the Latinx, Black, American Indian, as well as refugee populations. Your service ensures that these communities have equal access to care. Data continues to show that historically, more of these diverse communities, unfortunately, are not receiving that access, and having these activities will bring awareness to underlying health conditions and strategies geared to improve clinician-patient concordance and ensure leadership reflects the community they serve. My question for you is, how is actually St. Joseph's Hospital and furthermore CommonSpirit as a whole working on this set goal?
Well, first I'll just say that CommonSpirit as a whole is definitely aware of this, and they understand the gaps that exist, and they're committed to filling some of those gaps, which I think, I feel very lucky to work for an organization that, is proud to talk about that commitment. And, for example, they recently entered into a partnership with Morehouse School of Medicine with the commitment of training more Black clinicians, physicians, so that they can begin to address some of those underlying causes of these disparities. And at St. Joseph's, we're committed to this as well and take it very seriously. So, for example, for our medical learners that we have on campus, we are working to get them more involved in community health and allowing them to see firsthand some of the disparities that exist and why they exist. We're also trying really hard to train our current staff that we have right now to understand the causes of these disparities, to understand bias that exists, so that they can be aware of it and try to correct some of that. So, for example, earlier this year, we held an implicit bias training for all of our executive leadership at St. Joe's, as well as our community board. We also plan to host an anti-racism training for them, and definitely training is just the first part, And what my hope is that through these trainings we'll be able to, move into the growth phase, like you said, and be able to put in different programs or initiatives in place to really take action on some of those disparities.
Absolutely. And one thing that, as I mentioned, in the United States, we don't mandate a lot of these programs that are focusing on unconscious bias training and implicit bias training. But I want to bring in Dr. Mamas, who I hope can hear me, currently in the United Kingdom, because as it stands, after a conversation with Dr. Mamas, he had mentioned that in the United Kingdom in 2010, Parliament passed the Equity Act that implores a focus on anti-discrimination and actually requires health systems to undergo mandatory implicit bias training. These same initiatives, as I mentioned, have not been mandatory in the United States. So Dr. Mamas, 2 questions. Do you personally feel mandated training has changed the way you and your colleagues practice? If you can elaborate a little bit on that. And also, how has social media helped in a unified messaging?
Very important discussion, and it's a pleasure to see so many friends on the panel and so many people involved in the session. Just to highlight what the Equality Act involves, it was an act passed by Parliament in the United Kingdom in 2010, and it lists a number of protected characteristics. And the protected characteristics include age, disability, gender reassignment, marriage and civil partnership, race, religion or belief, sex, and sexual orientation. And therefore, it is illegal to cause harassment or discrimination in any of these groups. As part of this, we're required to undergo EDI training on a yearly basis. I think this is really important, because it highlights some of the either direct and, more importantly, from an institutional perspective, the indirect discrimination that can occur and how an institution delivers its services. I think this is key because often, we deliver services and we don't think how, from an institutional perspective, they may disadvantage certain groups of patients. So, for example, when we offer an outpatient service, how do we know that, for example, public transport can transport patients from particular demographics to see us? That's discrimination. Many of the tools that we use in risk stratification, for example, the GRACE score, are structurally racist. We're trying to publish a paper around this. And so it really makes us think about the services that we deliver, both from a personal and institutional perspective. And I think one of the really powerful parts of the Act is that by law, it's mandated that every year the NHS produces an equality report. And in the equality report, it will say, what are the makeup of its workforce. looking at health outcomes in individuals with protected characteristics, looking at the population that the hospital serves, and looking at, cardiovascular death, for example, for cardiologists, and how it differs amongst different racial groups, different age groups, and so forth. And this really helps us think about how we deliver services. I think from the social media perspective, it's key. I mean, we have very loud voices such as yours, such as Dr. Hayes, Dr. Ferdinand, many others on the panel, Dr. Waldman, who's joined us as a virtual participant, that highlight these sorts of issues. And certainly, social media has really helped make me think about the sorts of issues that we face as a community, and guided a lot of my research and my group's research around highlighting some of the disparities in different populations of patients. And many of the ideas that I have arise from conversations that we have in social media. So I think social media has really been key in identifying and facilitating some of the uncomfortable discussions that we have.
And I would say that I think it's actually ignited a lot of societies and healthcare organizations to think about talking about this and having the messaging around it. However, still, we're not seeing that mandate, which we're seeing for you in the United Kingdoms. And if we provide them this information, there has not always been success in recruiting and retaining diverse workforce, truthfully questioning the value of full relevance of actually these training programs. So the question really is this because our system is broke, or perhaps it's because our system was intentionally built this way, making it very hard to change old habits? I want to direct my next question to Dr. Hayes. As a national leader who developed programs to enhance the professional and personal development and mentorship of women and underrepresented minority physicians in order to promote a more diverse workforce in the field of medicine, what has worked, and where do you believe we still have room for improvement, as well as what may be an ideal solution or approach?
So I'll just start by saying that mentoring and sponsoring are really, really important for women and minoritized individuals, or those who are onlys or firsts, but it is insufficient, because you can mentor the heck out of someone, but if they then enter with new skills and professional development, enter an environment in which they are daily implicitly and explicitly told they don't belong or shouldn't be there or aren't worthy, that is the situation we basically have right now. I can't tell you how many women go and they learn new skills and they're ready to be a leader in their organizations, but the organization hasn't changed. So one thing I would say is those things are very important, but there has to be a significant commitment from top leadership. And that is not just talking about it. That is a commitment to a different way to recruit. That is a different way to select leaders in that organization. That is an investment of money and people, and perhaps hiring in novel ways, such as posse hiring, where you might bring in, if you want to diversify your staff, you bring in a whole team of people, not 3 different specialists, and so you don't have onlys. So I think thinking about novel ways, I think the other aspect that we have to remember is there are still many barriers in the pathway, right? And I like to use the term pathway, not pipeline, for a variety of reasons, but because some of my indigenous people, particularly in the US, the whole pipeline is a triggering issue. But if you look at a pathway, it often is a way that is not straight. So financial barriers to professional schools for nursing and physicians. So how might we figure out ways to offset those costs and those barriers? If you are the first, so maybe not mentoring that woman who's mid-career, but looking at how can we get in the middle school to talk about health careers, for instance, and what it'll take in the next 3 or 4 years in high school in order to do that, and with role models. So there isn't a single thing, but if we do not have leadership, not just mandating training, because training doesn't, but to turn the organizations upside down, so when we're hiring and recruiting, we have fair interview and selection processes. Because there's so many, we can talk about the leaky pipeline or the broken rung, on the ladder, but there's so many places for people who don't have the support to fall down. And then there's also, once they get there, many of them don't want to go any farther, or they want to leave because of the microaggressions and the feeling of not belonging.
Absolutely. And I honestly think that we have to hold ourselves accountable to the same way that we must hold our leadership accountable. As you said, I think it begins up at the top with leadership, without a doubt. One thing I'd like to include Dr. Falluji on, who also is joining us virtually from Lexington, Kentucky. Dr. Falluji, as the VP of the CV service line for CommonSpirit Health, the largest non-for-profit healthcare system in the United States, how do you envision a more inclusive work environment that actually reflects the population at large?
Yeah, well, thank you again for inviting me, Dr. Bond, for this incredible symposium and to be in the presence of such outstanding faculty. It's an honor. Yeah, so I've been in this post for the past, and I wish I had a prepared question sent my way so I can prepare better. But I will try to go through some of the ideas and thoughts that we've talked about. But I've been in this post for about 11 months. Our organization is mission-oriented, non-for-profit, faith-based. It is embedded in our mission and vision, a strategy for the future to be focused on the most vulnerable and to eliminate the disparity of care that we notice. I came to this post with no clarity, no experience in this particular subject. So I'm probably the least experienced person but on this panel, but I think we started with a very eloquent expression of the dynamic that we're in today, when the difference between Hurricane Betsy and Hurricane Katrina is still pretty much the same. We're still in the same place, which is a travesty. In my mind, equity is a societal proposition. So I will share the first Dr. Ferdinand's statement that training programs, and I'm a little cynical about that. I do think that we can only do what we can, though, so we will work within the confines of our workplace, work environment, within the capacity that we have, to increase access and to promote opportunities. I'm not a big believer in equity when it comes to outcome. I'm very specific. I'm a big believer in equity on opportunity. I do, however, believe equity on opportunity is very difficult to measure. Dr. Mamas spoke about a very important thing. You can provide access to free healthcare, but if people don't have gas money to get from rural Kentucky to see me, guess what? That free appointment was a waste and it didn't work. So it is a complicated question. It is a question that we have to address because it affects us tremendously. And to provide all of our population with the opportunity, with the dignity that they deserve, requires a commitment from not one organization or two and one physician or two. It requires a collaborative work. But we have to be very cautious because I do feel there is a confirmation bias. I notice in this country there is a divide. So the social media piece is where people go to hear what they like to hear and confirm what they believe. And there is always another narrative that is completely maybe irrational, but it's there and it's confirming the ideas and obfuscating the conversation. So awareness is key. For a clinician like myself who works in an area that is very, I would say, homogeneous. I'm in the eastern part of Kentucky, so it's mostly a white population. Socioeconomic differences is the key. Education is the key. The sense and the interaction with a physician and their authority, the ability to ask the next question or not based on what you perceive of physicians is another question that comes to mind. And this is also a vulnerable population of patients that I would like to focus on. I will conclude by saying the participation of women in our field, especially in the CV service line of CommonSpirit, and you and I had this conversation, is an active process that we would like to advance. I would like us to be an example that people say, this is where you would want to go because this organization recognizes the need for advancing the career of the female physician, and in cardiovascular at least, but in other specialty, obviously, and to look at the barriers as they see it. And that's the data that we need to accumulate. Now, I'm actually, as you know, continuously stating that I don't want to hear about disparity because I actually heard about that when I was a trainee in the 1990s. I want to hear about solutions. And I want to hear why solutions fail and why all these workshops and anti-racism and anti-bias workshops have not delivered what it has promised. Careers were built, companies were made, resumes were filled, but the outcome is the same. So it's an embarrassment because we haven't made, a significant movement in the right direction, but we are definitely moving in the right direction. And the hope is that we can escalate. So in a nutshell, I think that's what our organization will do. In cardiovascular, I don't know how much of the 20% of the cardiologist workforce is related to personal choice. I have to understand that piece. 99% of bricklayers are men. I don't propose that it should be 50-50. We have to give options to people to make choices. But we have to understand that the fact that they didn't choose to do cardiology or cardiac surgery has nothing to do with barriers rather than with choices. And we have to understand why these choices were made so that we can rectify what could be a barrier that we're not seeing or they're encountering and unable to express. And I think obviously that work is very important and is tremendous. And it's a big task that requires all these incredible and talented scientists and professors of medicines and researchers and advocates like yourself to help us understand so we can make the right decisions.
Thank you, Dr. Falluji. I think we can all agree that diversity in medicine is so important, but moving beyond just strategies to increase this pipeline or pathway, as Dr. Hayes very nicely mentioned, is what we need to do. As you said, we need more strategies to address the plight that diverse populations tend to face due to misogyny, discrimination, and racism that could lead to recruitment, retention, and more inclusive work environments. I want to just close by asking Dr. Ferdinand if he has any final thoughts. I know you were taking some notes, and I'm just interested to see your thoughts in conclusion of this wonderful panel discussion.
Well, I think it's good that we address these issues. You've heard, those of you who are leading EDI sessions, that that's not enough, that you really have to have truthful, honest, and open discussion among the members of your staff about language and behavior. If a person just watches a video or somebody flies in and gives a seminar and you get the little stamp from the dean's office that you attended, that's not going to make a difference. One thing that I think Tulane is doing that is good, we have a professionalism committee, and I sit on that committee. It's 3 of us. And we allow students, residents, fellows, attendings who've had inappropriate occurrences happen in terms of language and behavior to report to that committee. And we have a means in which we counsel or just have what we call a cup of coffee, where we discuss with the person who had the inappropriate behavior. It's not punitive, it's not HR, it doesn't, quote, go into their records. And the idea is going back to the golf game that I talked about, people kind of hit the ball where it is. I want to assume that most of us in medicine really have good hearts and we're trying to do the right thing. And sometimes our actions and our words are inappropriate. And if there's a mechanism by which it can be brought to our attention and we can correct our behavior, that's certainly better than either holding a grudge or running down to the HR office and trying to put a report so that the person gets fired or punished. I don't think punitive actions is going to go a long way to make the type of changes. The other thing that I wrote down was silverbacks. Silverback gorillas are the leaders of their clan. In New Orleans, we have black men who go into the schools and try to talk to the young men, because for many of them, they really don't see much of a life beyond 19, 20 years of age, which is why they do horrendous types of criminal behavior, because what difference does it make? They're not going to be a doctor, a lawyer, accountant, and they tried to play basketball, but they weren't that good. So we try to give them alternatives of self-perfections in terms of what they would be. I came from public schools in New Orleans. I come from a segregated South. I didn't go to school with white folks. And I learned because my mother and my father and everybody in the neighborhood put everything they were into me. And I remember them talking to me about, you're going to be great, you're going to do this, you're going to do that. And I kind of remembered it as a kid, and I never understood why they keep saying that. Because they knew as you go into the outer world, people are going to say you're not worthy, that you shouldn't be here, that you don't have X, Y, Z skills. So we need to nurture children from a young age that they can be agents of change in their communities and in the general world. So I'll keep it short. For a panel discussion, it's always hard because we give these little nuggets of insight or information, but it really doesn't give you the full sense of how deep this is. My question to Dr. Hayes this morning is because you look at these graphs and we keep looking at these data, and it's a little bit distressing.
Absolutely. And as you said, we cannot solve this in a 20 to 30-minute panel discussion, but I think it's important that we're having these conversations and we're getting more comfortable having these conversations. We should be having them on a day-to-day basis with ourselves, with our colleagues, and even with our patients, most importantly with our patients. So with that, I want to thank all of you panelists. Thank you so much, faculty speakers, for this your exceptional job.
Thank you for your leading.
Oh, thank you. We are going to take another 10-minute break for those, and Dr. Ferdinand will be back to give us some information on lipids as well as a few of our other amazing faculty speakers. So please feel free to go out to the exhibitors and get some food. Thank you.